Welcome to the second episode of IJC, an online journal club brought to you by ESCRS, where we aim to discuss the latest research with an expert panel with two main aims: to refine your practice in cataract surgery with the latest evidence, and also to refine your knowledge of research methods. I'm Basak Bostanci Ceran, and I'm an assistant professor at Okan University, Istanbul, Turkey. I would like to introduce my co-host, Dr. Imran Yusuf, who is an ophthalmology resident and also a PhD candidate at the University of Oxford, Oxford Eye Hospital, United Kingdom. We have a marvelous expert panel today. Professor Thomas Kohnen, who is a professor of ophthalmology in Frankfurt, Germany, and also he is the European editor of JCRS, and Dr. Adi Abulafia, who is the chairman of Israeli Society of Cataract Surgery from Jerusalem. I want to remind you some tips for today's discussion. So everyone will be muted throughout the entire presentation to avoid background noise. At the bottom of the Zoom screen, there's a Q&A button, which you can click to post your questions and comments for the panel. So don't be shy and ask your questions, and your questions will be answered by the panel at the end of the presentation as time permits. And also don't forget, a recording of today's IJC will be available on the ESCRS Facebook page and YouTube channel. So before we start discussing today's article, let's run a quick poll. Can we have the questions, please? First question. Do you think eyes with previous intravitreal injections have a higher risk of posterior capsular rupture, even though they have no visible preoperative damage to the capsule or the lens? Okay, so 64% said yes. Okay, second question, please. In your current clinical practice, do you inform patients undergoing cataract surgery who had previous intravitreal injections that they have a higher risk of complications? Okay, 50-50. And our last question. In your current clinical practice, or in your experience, are junior trainees discouraged from undertaking cataract surgery on patients with previous intravitreal injections? Are these cases left to senior surgeons, or junior trainers also perform these cases? Okay, so junior trainees also perform this case in the majority. So at this time, I will leave the word to Dr. Yusuf to introduce today's paper.
Thank you, Basak, for that summary and running the poll. So I hope you've all had a chance to have a look at the paper and to have read it. But for those who haven't, and just to recap, I'm just going to go through the main findings of the paper. So this was a paper reported from the United Kingdom from a teaching hospital in East London called Whipps Cross. And so this was a retrospective case records analysis where this particular team looked at a number of cataract operations in patients with previous intravitreal injections and those without, and essentially tried to compare the posterior capsular rupture rate between the two groups. And of course, we'll have a look at the methodology and we'll see whether you think their conclusions are justified. So just to summarize their findings, this table is quite an informative one. This compares the two groups and also presents the overall data. So you can see that the previous intravitreal injection group were defined as anyone who's had any previous intravitreal injection. There were 108 of those patients. There's a group without any previous intravitreal injections. There were 3,939 and overall about 4,000 patients. You can see that in the group with previous intravitreal injections, their age was slightly higher. They've also run a statistical test and found that's just evades significance at people's 0.053, and we'll come back to that. They found there was no significant difference in terms of the laterality or the gender. In terms of ethnicity, there did appear to be a difference, and we will discuss the reasons for that. You can see there's a higher percentage of white or white British patients in the previous injection group versus the group that didn't have injections. And again, for diabetic status, there are actually more patients in the group that didn't have intravitreal injections at 47.9% than there were in the group that did, which is quite surprising, I suppose, if you think that diabetic macular edema is an indication for intravitreal therapy. And it also presents the co-pathologies, and as you would expect, many more patients with AMD in the previous injection group versus the other group. And you can read the other co-pathologies as well. And you can see that AMD and diabetes are statistically significant when the groups are compared, as you would entirely expect, given that intravitreal therapies are mostly given for those reasons. Here's the histogram plot showing the number of injections and the number of cases in each of those bins. And pretty much as you'd expect, there are obviously more patients who had fewer injections and fewer patients who have had more injections. So that just gives you an idea of the risk profile, I suppose, if injections were to be a risk factor. And this table is probably the most informative. This compares not the overall rate of PC rupture, but the rate within the groups. So for patients who didn't have any intravitreal therapy, the rate of PC rupture was 1.88%. For those who did have intravitreal injections, the overall risk of PC rupture was 9.26%. And they also did a sub-analysis based on the number of injections. So those who had 10 or less, their PC rupture rate was 6.06. And for those who had more than 10 injections, their PC rupture rate was 14.3. And I think this is perhaps a little bit superfluous to the paper, but they also wanted to identify sort of when in the surgery the PC rupture occurred in the group that had previous intravitreal therapies. And I suppose you can also see there that there are some that happened during the phaco, some that happened earlier during hydrodissection, some that happened later. So I suppose they've given the information, but I suppose it's not directly relevant to the findings. So I'll just leave you with this slide. This is what they thought was known before and what they felt the paper added to that. So as we go along, you can decide for yourself whether you think those things that the paper thinks, the authors think they've added really are something new. So those are the main findings of the paper. So I'll stop my screen share now. And now that you've heard all of that, what I would just recommend you do is to make sure you put some questions to us through the Q&A. You can't ask questions by voice, but certainly you can by Q&A. So I would strongly encourage you to ask as many questions as you can as you think about them as we go through the discussion. So the faculty, Basak and I, we're going to ask our faculty some questions. Perhaps Dr. Kohnen, Professor Kohnen, perhaps I could start with you. And obviously, you being the European Associate Editor for JCRS, obviously you've got a lot of experience with analysing and critically appraising papers. And of course, what we hope to do in this is to demonstrate critical appraisal for our audience who obviously do write papers as ophthalmologists and think about study design. In this particular paper, Professor Kohnen, one thing I wanted to ask was, for this particular analysis, they, as I showed you in that table, clearly age is a big confounder when it comes to the risk of PC rupture. We do know that an increasing age does predict a greater risk of PC rupture. I think most people acknowledge that. And of course, there was a difference between the groups in terms of age. Now, do you think that they accounted for that in their analysis?
Okay. I mean, we have, first of all, let me comment, let me start by doing this paper. First of all, if I look at this paper, it's written on 4 pages, which is a very good sign because it has very precise methods. It's not have a long discussion. Sometimes that's very helpful because they come right to the topic. So when I look at it from an editor point of view, when I read this journal with this issue, I was interested in this paper, which is a good thing. Usually I rate these articles, I mean, let me start the other way around. Obviously, one of my co-editors has seen this paper. I cannot remember if I was the one, because as the editor of this journal, I'm doing, you know, like 500 articles per year. So sometimes you don't remember if you were the editor, and I just have to ask my secretary sometimes. Nevertheless, this is a retrospective analysis, which in itself sometimes has some weaknesses. The message is clear here. You get more PCO ruptures if you have previous vitreal injections. And we come to this in a later scenario. So let's go to your question to the age. I mean, you had not much higher age in the IV injections, 73.8 versus no previous was 71, but this were 4,000 eyes, the other one was only 100 eyes. So realistically, that is not a real comparison. You had to do potentially a prospective analysis where you really do a prospective study, and you could most likely then see another difference. But from the first graph, and this is one of the only papers I have seen, that maybe age is a limiting factor, but I don't see that is so relevant. I mean, the p-value shows here a little difference, but not so relevant in my opinion.
Okay, okay, that's fine. Just one question related to that, because obviously you're an editor. Do you ever check statistics from papers that are submitted? The reason I ask that, of course, is the recent COVID papers published in The Lancet. Clearly there was a body which extracted the data and then it was published and then retracted. So I suppose my question is, as an editor, clearly journals might be a little bit wary of that sort of thing, either not knowing the provenance or where the data's come from, or B, not trusting the statistical analysis. So the question is, do journals ever check statistical analysis if you feel it's important?
Well, we do. If we feel that the statistics are not incorrect, then we do. But basically, what I have to say is when we cannot say, assuming you have 1,500 articles submitted to your journal, the first thing what I always do is I go to the message part in this paper, and I go to the last thing and I take a look at the statistics. If there is not really a power estimation or a power calculation in a prospective study, and in retrospective it would be a power estimation, then I tend to, grade these articles not so significant, because if the statistics are not right, if you do comparison, then you have a problem in really making something out of it. So I check always the statistics in every paper. And if there is a first hint that the statistics is not done correctly, then at least this is already a reason for rejecting this article. You have to understand that the JCRS has currently a rejection rate of 70-75%, meaning maximum 3 articles out of 10 are going to be finally accepted for publication. So if the statistics is incorrect and they come up with a conclusion, making the conclusion that it's significant, that this is better than that, and the statistics are not right, we cannot accept these articles. To your question in particular, you talking more like, where comes the data from? Is the data, is it correct or not correct? That's really difficult for us to check. And so we don't do this. We have to trust, and it's a responsibility of the authors. Unfortunately, what happened recently, I had it yesterday or 5 days ago, a paper where we had to contact the institution because a person from an institution wrote us a letter and said, because they had an internal fight, told us that the statistics of this article was not incorrect, the numbers were incorrect, and then it really becomes difficult. Then we have to go back as editors, and we have not even to talk to the people. We go right to the institution, and that's really a very difficult situation.
Yeah, okay. The reason I mention is that I just double checked the statistics on the age, because you can run a t-test if you know the mean standard deviation and n number. You can obviously run those statistics yourself, and I did that, and the p-value for the age comes up at 0.03, which is obviously significant. But they quoted it as 0.05, which is insignificant.
Okay.
And I just wonder whether that had a knock-on effect in terms of how they design their analysis. And I suppose on that question, I want to bring in Dr. Abulafia about that. In fact, broadly, what do you think of the paper, Dr. Abulafia? I will leave you free to make your comments as you wish.
Yeah, well, I think it's an important paper because it raises our awareness for the high risk of posterior capsular tears in this population. But if I look at the limitations of the studies, I have some thoughts. I mean, yeah, just my thoughts. So as Professor Kohnen said, it's a retrospective study, so this is a limitation, of course, and it's also coming from a single center. But it's a relatively small cohort. If you compare it to the two other published studies from the UK that came in 2016 and 2017 in the ophthalmology and the American Journal of Ophthalmology. I mean, the second one came from Moorfields, I think. They had more than 60,000 cases there, so it's much bigger. And one thought that I had, I mean, that jumped to my thoughts when I read this paper is that it's only having a univariate analysis for checking the odds ratio. So they didn't do any multivariate analysis, which the other two papers did. And they should account for, as you mentioned, the age, the grade of the cataract surgeon, the advanced cataract category. And you can also put in the number of previous IV injections and maybe even the grade of the healthcare professional which was administering the IV therapy. So I think all this can when you put all of this together, you might get different numbers, as the other papers had. So I mean, all papers had found that there's a higher risk, but not with these percentages.
Because the percentages are slightly higher than you'd expect in the injection group.
And also I was missing, I don't know if you can get it in a retrospective study, but the grade of the experience of the ophthalmologists who evaluated the integrity of the capsule in the slit lamp. So, I mean, if you have a very junior resident that is doing the pre-op examination, you might miss, signs that more experienced ophthalmologists wouldn't.
So I want to cut in and ask a question. Do you think only evaluating the capsule with the biomicroscope is enough for detecting small, like subtle changes in the posterior capsule in such cases?
Well, Adi, go ahead.
Yeah, well, in most facilities, this is what we have. I mean, you might use OCT, but I don't have much experience of finding these subtle changes with an imaging device. But many times you can see clues for that, like the track of the needle, something changed with the anterior contour of the anterior capsule, things like this. And of course, if you have immediate cataract history of evolving cataract after the injection, I mean, it's quite obvious.
I would say, Adi, to this point, I mean, we had it's a very good factor to put this in to look at the posterior capsule, because we only had here a total of PC ruptures, which was a small number. So if you have one or two under interpretation of the posterior capsule, the whole statistics will change, because you have only 10, and let's assume they were not graded correctly, then you may come up with the conclusion that just the injection per se is a reason for the capsule rupture, rather than the injection which has maybe perforated the posterior capsule. And that's the main thing here. What we would like to know is, if you give 30 injections correctly done, 100% correctly done, not subtly the posterior capsule, is then really the incidence so much higher. If you have a case where you really touch the capsule with an injection, which sometimes happens, then of course, clearly you have an increased incidence of posterior ruptures.
Thank you.
Yeah, very good. Okay. I suppose just adding to both what you've both said, clearly there were things they probably could have looked at, but presumably the numbers weren't large enough for them to sub-analyze some of the data in terms of the seniority of the surgeon, for example, all the factors, Adi, that you mentioned there. So I wonder whether it was simply because the study wasn't large enough to allow them to comment on, or even perform a multivariate analysis, perhaps, if the numbers weren't large enough. I was quite interested in the fact that there were a lot, because this study took place in Eastern London, where there was a high percentage of diabetic patients. So in the initial table I showed you, in the group that didn't have intravitreal injections, there was a very high proportion of diabetics in that group. Do you think that had any influence on the findings of the study, or not? I'm just commenting because it seemed unusual in that regard to have 40%.
It's hard to say.
Yeah.
47%, right?
Yeah, that to me seems quite high, but it may just be the part of the country where the study was taken.
I mean, the diabetic eye, because you have a high incidence here of diabetes, is a risk factor for cataract surgery per se. I mean, you know, what I would be, but obviously there is a lot, and I ask myself the same question. You do the intravitreal injection because of diabetes, right? Diabetes macular edema, this is not the main indication, at least in our country. It's more the AMD, which has the injections been done. And we also don't know which kind of really injection was given, right? Do we know exactly, was it only anti-VEGF or have they used other types of things? These are all questions in a retrospective study which you can difficultly, or you have a difficulty to answer because the numbers are not there. And all the other things which Adi just pointed out, the multivariant analysis that you would like to know, the experience of the surgeon, the hardness of the cataract and so on. So this is all really difficult to understand. Nevertheless, it's a great study in terms of a retrospective. It gives you a hint, but in order to come to a final conclusion, you have to do a large prospective study. Most likely we will find a similar, very similar, and we all should be very careful. As Adi pointed out, we should be very careful when we do cataract surgery on patients who had multiple injections. Whatever it is, if it's just the incidence of posterior rupture because of the pharmacological agent in the vitreous, or because they had a wrong therapy touching the posterior capsule, but definitely surgeons should be aware of this. And that comes out of this study and also from the two other studies which were just mentioned.
It's obviously interesting, the type of agent, because of course we know ochraplasmin, which is also given as an intravitreal injection, can affect the zonules and probably can increase the risk of a subsequent cataract operation. I'd be very interested to know amongst the anti-VEGFs if there was any difference in the risk, with those agents. I suppose this study didn't really look for them, but it's possible. We just haven't sort of examined that, I suppose. One thing about the paper I was quite interested in is that clearly within a period, a lot of patients will have the second eye surgery done. And this paper didn't really say for those patients who had both eyes done, how they selected which eye went into that paper. Because we do know from experience that if a patient's had a complication with the first eye, they're probably more likely to get a senior surgeon for their second eye. So whilst I thought it was interesting, the paper didn't say or make specific how they chose which eye went into the paper. I don't know whether you read that and what your thoughts were about that. And if you were designing the study, how would you specify the eye?
Yes, I completely agree with you. I mean, this is another limitation of the study. I mean, a potential limitation because it was not mentioned. But if I had to design this study, I would probably take the first eye that had surgery, and that's it.
Yeah.
Yeah, you should. This is always a problem if you mix first and second eye and are not clear about the method. Then you have a bias, or you have a statistical point which you cannot really, extract at the end of the day. So this is a big question always in ophthalmology. If you have a patient with two eyes, which eye to take, and usually in very good analysis, you usually take only one eye because it's a paired organ, and therefore you should not take, in these data sets, you should not take both eyes.
Absolutely, absolutely, yeah.
And also, I'm sorry, and also the posterior capsule rupture in the fellow eye increases the risk of posterior capsule in the other eye, and maybe there will be a bias because more trained surgeons will be prone to do the second eye if the patient already had a rupture in the first eye. So,
yeah, but this is okay. Let's go back to the paper because we're doing a journal club here. I mean, these are all questions which a young researcher, older researcher, whoever, can take from this paper and say, okay, I'm interested. Because if you go to the contents of the Journal of Cataract and Refractive of this February issue, 2020, I wrote the editorial in this. And if you look at the content page, what we in the journal do, we have one sentence below. And it reads, previous intravitreal anti-VEGF injections were a significant risk factor for PCR during cataract surgery, and therefore, there was a statistically and clinically significant dose-related risk. And I think that's true, that the paper has shown this, but we can evaluate on this, and we would do further studies to get more into detail of this paper or of this outcome. And therefore, I think it's a first good retrospective analysis. There have been 2 others, but there are a lot of critiques which you still can do. But you have a high number because you have 4,000 eyes, and that's not bad.
Professor Kohnen, so there are some questions in the Q&A pool. So at this point, I want to ask one relevant question to what you just said. Ruth Lepid-Gorsak just asked, would you say that a long projected trajectory for an IV injection, intravitreal injection, is an indication for early cataract surgery in such patients?
Give me the question again. Is there an indication that?
So the patient will receive a lot of injections. Yes. Should we do an early cataract surgery in these patients before he gets the injections?
That's a good question. Usually when they're 73 age, then usually patients have cataract in a way. And it depends really on how you see cataract surgery. If you see it as cataract or see it as refractive cataract procedure, I think that many patients, potentially have this. Most of our patients who are coming for long-term injections are pseudophakic, I have to say. So my clinical experience is that most of our injections, I did just today 15 injections and 10 cataracts. So I would say that most of our patients have usually these injections and have cataract surgery already. If they don't have it, realistically, after a certain period, they all get some cataract formation, and you have to extract the lens. But yeah.
Okay.
Can I comment?
Please do, Adi. Yeah. Please do.
Well, I think this is a great question, which we asked ourselves in my department many times. I mean, should we, looking at this paper and the other paper from the UK, should we do an early cataract surgeries in these patients? I mean, there are pros and cons, of course. And if you look at the Moorfield's paper, the one from Moorfield, it says that there's no cumulative risk. So this is one thing against it. But if you think that you need to follow up these patients and to look at their OCTs, and then if they have cataract, then you have sometimes issues of interpreting the OCT. And as Professor Kohnen said, most of these patients will have a certain degree of cataract in this age. So it's a good question, which I don't have like a conclusive answer for that. And we might think of doing a prospective study on this issue, on what will be the benefit of early cataract surgery in this type of population.
I would, another clinical aspect, I would, from the experience I have now over 25, 30 years in cataract surgery, I think that we all know if you have a patient which comes for 95 and has cataracts, and you have to do the cataract, usually it's a difficult case because the cataracts are so hard and you ask yourself, Jesus Christ, why was that patient not here 15 years ago when he was 80? And I just can tell you this from my mother-in-law, we had cataract surgery to her in an earlier stage, because we know in 5 years or in 2 years or in 3 years, she has some deficiency because she has some bone problems. So I would like rather to do this now than do it at a later stage. So I think that this is a good indicator for doing it earlier, because you have less complications. Because we know the cataracts are harder, and then particularly in these injections, we know also there might be some influence of the pharmacological agent in the vitreous, that you have, not only capsule problems, but also maybe have zonular problems, and therefore you would do earlier treatment of the cataract.
I can tell you're a confident surgeon, Professor Kohnen. If you do your mother-in-law's cataract, you must have nerves of steel.
Well, I did all my children, not cataract, but I had to suture everybody of them on her head or anything. So I'm not doing the surgery on relatives. So
I suppose a link.
Sorry that I don't have the fear.
Yeah. Well, it was very wise of you to avoid that. Adi, may I ask you, given the findings of this paper and the other papers that you mentioned, how do your service where you work, how do you handle patients who've become for cataract surgery, who've had previous intravitreal injections? What are your kind of considerations when you're approaching that case?
Okay, so
Okay.
Sorry.
Go ahead, Adi, go ahead.
Professor Kohnen.
No, go ahead.
Okay, thanks. So the first thing, it's we look very, we do a very detailed slit lamp examination. And if there's any sign of suspicion of problems with the capsule integrity, then we will have a vitreoretinal surgeon on standby, and we take all the precautions like that we have a tear there. We would also inform the patients, all these patients, of the increased risks, and we'll write it down in the informed consent as well. In the surgery itself, we would another thing that we do sometimes when you do, in our facilities, we do the pre-op. It can take some time until they have the surgery, and then they will have another injection in that period. So we have a slit lamp in the waiting room in the OR, and we will re-examine them the same day, just to see that there's nothing new going on there. Then we will usually, and a more experienced surgeon will do that. Same as all other high-risk cataracts. I don't know, maybe you are overprotective in this, but this is our policy. And if there's no signs, in the slit lamp examination for a touch in the capsule, we would probably do more or less the same as a standard case. But if we have any suspicion, then we will do same as we do for polar cataract. So we'll do a delineation first. We'll take the settings down. Maybe yes or no, like a very gentle hydrodissection. I use for these cases anterior chamber maintainer, just to make sure that the anterior chamber will not collapse and the vitreous might prolapse. That's it. And as with all cases, we'll have a biometry printouts with a 3-piece IOL there for the sulcus or for optic capture, and make sure that we have anterior vitrectomy on standby and triamcinolone.
It's a good, there were a lot of interesting aspects in this. I would not go into detail again, because we do all this precaution, we do informed consent, we let the patient go. But the real question is, let's say you know that the posterior capsule is ruptured. Then you have to do surgery, and I just added a couple of things which I do. I usually do in these cases, I like to protect. My number one thing I would like to protect is to lose the nucleus into the vitreous. That's number one. I don't have a problem if vitreous comes into the anterior chamber, because I do so many vitrectomies, and I'm a posterior I do posterior segment surgery myself. But what I like to do is I like to get this nucleus. And therefore, in many of these cases, very similar to what Dr. Abulafia said, I would try to make sure that I get this nucleus in a way where I can do still a phacoemulsification correctly. So with other words, I sometimes even do supranuclear, suprapupil cataract surgery because I try to get this nucleus up and protect the posterior capsule, not losing the lens. I'd have no problem if you get a little bit of cortex. That's not the big thing. And of course, we have to prepare for putting a sulcus lens, but very often, depending on how big the capsular rupture is, you still can put a capsular, an IOL in the capsular bag. But this all depends on the specific situation. But very careful and very important is that you check the status of the lens. And if you have the suspicion that there is a rupture, then you have just to do a totally different surgery, and it should be done by the most experienced surgeon. That's what we do. We don't give this to beginners, never. Because it's a very, almost a guarantee that you lose this. So why?
Yeah, it's interesting hearing both of your points that you deliberately have a senior surgeon doing the operation, because in our poll earlier, I think we had the majority of attendees say that the majority of their settings, the juniors also do these cases. So that's a very interesting, clinically important point from these papers, is how these cases are managed and who does the surgery. So I'm glad you brought up those points. One question which I might ask, which is a little bit sort of a clinical facet, but slightly different from what we've talked about. There's a question from Italy from one of our attendees. It's about the fact that cataract surgery, or the evidence for cataract surgery, re-stimulating the activity of a previously quiescent CNV. So in other words, does cataract surgery increase the risk of reactivation in AMD?
Oh.
Thoughts on that?
Well, there are many papers in the literature which have said yes or no. I don't think that we have a real clear evidence that if you do cataract surgery that you increase the risk. And you're talking about patients who do not have, or maybe just have drusen, and you have to do cataract surgery, and that is your question, right?
Well, I think the question relates to those who've previously been treated with anti-VEGFs, who have AMD, and then obviously they're quiescent, and then the cataract surgery is undertaken. And the question is, does cataract surgery accelerate the reactivation of that quiet CNV?
Well, I'm not aware of any evidence supporting that, but.
Yeah, I'm not aware. Maybe we have to do a literature search, and maybe there is a paper who has shown this. I'm not so sure.
It's a good question. Yeah, I wasn't sure about the answer to that either.
No, exactly.
Yeah. All right. Basak, do you have any further questions for we're giving them an easy time, I think.
Yeah, well, we have wonderful questions about the statistics, actually, but I think we have limited time and we have to close our discussion.
Let's do that. Were there any other comments, Dr. Abulafia, from you about the paper? Anything you wanted to mention which we haven't asked you about?
No, I just want to thank you for inviting me for this wonderful session and great initiative.
No, it was a pleasure to have you. Professor Kohnen, did you have anything else you wanted to add in any way?
Well, no. I'm not. I'm just thinking about, from a journal perspective, what can I teach people if they do this? I think that it shows. These papers show really that you can do studies, even, because it's a retrospective analysis which has some needs, something what we can learn from it. So it's a good thing to publish these articles and to get the information, and we think about it because it's a big problem. I mean, cataract surgery and AMD is the number 1 and number 2 treatments in the world, if you look at it. So to have information about this is very important. And I think this is a typical study which a group of people can do, even younger researchers can do, because they pull the data, they go into a database and they figure this out. So that's very good information. And therefore, I in a way like that paper, and I'm happy that we have published it, although there have been 2 other articles maybe with bigger numbers, but still, I think it's a great paper which has been seen here in JCRS, and I think that's a paper which will be highly cited.
And it's encouragement to all the residents listening, both now and in the future. You know,
that was my idea. That was my idea.
Yeah. So yeah. So look through all your medical records and do your studies and submit them to JCRS probably. So just to finish off, because we've only got a few minutes remaining, I just thought I'd show this summary slide again, where they say that they've added there's a significant risk of PCR with previous injections. That they found that they thought there was increased cumulative risk with more injections. And also the point that we sort of mentioned together as a group, that it's important to know this and to make appropriate surgical preparations for the higher risk of PC rupture. And I just want to show this next slide, which Dr. Abulafia and both Professor Kohnen and Dr. Abulafia were referring to. These are 2 other papers published that look at the same thing. So if anybody was interested in this topic and wanted to, in particular, look at the different methodologies that could be used, I would strongly recommend you have a look at these 2 papers, because then it allows you to compare their methodology with the paper we've just read and give you a better understanding of different ways of doing or measuring the same thing. I just hand over to Basak to add her thanks, but for myself, I just want to thank our panelists. They've been fantastic, lots of wisdom there. And so thank you very much for your time, Professor Kohnen and Dr. Abulafia. So thank you very much.
Thank you.
I also would like to remind you that our next episode will be on 26th of August on Wednesday at the same time, 7 p.m. UK. And we are going to be discussing the factors risk factors for drop nucleus in cataract surgery as reflected by the European Registry of Quality Outcomes for Cataract and Refractive Surgery. And our guest panelists will be Wolfgang Meyer from Germany and Paul Rosen from United Kingdom.
Okay,
so I also would like to thank all the participants and our guest panel for being with us. It was an honor to have you here, and we are hoping to see you again.
Yeah. We also have that poll to run, Basak. About
that. Yeah, we forgot the poll. Okay, can we have the questions, please? Okay. Finally, will this paper change your practice? So yeah. 56 said yes. And the last one, please. Do you think junior surgeons less than 3 years of experience should undertake cataract surgery on these patients? And now this time 61 said no. Okay.
So there's been a swing. So before 65 said yes. So so clearly the discussion has really had an impact on people's opinions. So that's really encouraging. So I'd just like to, on behalf of everybody here, wrap this up, say thank you to all who attended. And again, thank you to our expert panel. And we look forward to seeing you next time. So keep a note of the date and we'll send out a link for you to register shortly. Thank you very much. So yeah, I'd just like to thank everybody, and I'm sure Basak also would, for attending, and we'll see you next time.
Yes. Bye-bye.
Bye-bye.
Goodbye, everybody.